So my first mission here is to tell you a little bit about the age-friendly health system, not in terms of the national movement. You'll hear more about that tomorrow from Kellyanne Pevin from the Institute for Healthcare Improvement, but more in terms of the background and specifics around what Baystate has done thus far to give you a sense of where we're coming from, what some of the active programs are, and also what some of the steps are moving forward. So we're going to begin by looking at a couple of broad barriers to the provision of excellent geriatrics care for older adults, and think for a moment about how the age-friendly health system begins to minimize some of those barriers. Look at high points in terms of where Baystate has come so far, and think a little bit about where we're heading in the future. So the first issue is one that I think everybody on the call is well aware of. You can see and already know that the proportion of the population in the United States that aging is consistently rising. However, the numbers and proportion of geriatrics physicians has not risen. That's the graph that you see on my right. And the same would be equally true, not just for the docs, but for the social workers, the gero-certified nurses, et cetera. So basically, there's a rising need and a mismatch in terms of a highly trained workforce. If we look at this map of Massachusetts, it highlights it in terms of our state and regional realities. The little dots that you see all over are depicting the concentration of geriatrics physicians, where they are located, and the dark color on the map indicates the numbers of older adults in those areas who have multiple medical problems, what the geriatricians frequently refer to as multimorbidity. And again, this would be heightened if we thought about the fact that many conditions are undiagnosed, as well as the fact that this is only reflecting docs, right? So the same thing, again, would be true for the social workers, the nurses, the community health workers. You pick it. So if it was limited to where you had access to teams, the disparity would be even more striking. Another challenge, I think, is, frankly, attitudes towards aging. It's the rising number of older adults is frequently described as the, quote, silver tsunami, close quotes. Well, do we really want to think about our older family members and friends as an impending disaster? It's actually a major public health success, and these folks have enormous things that they can still offer to the community, to the people who love them. The photograph you see is my mother at my daughter's wedding several years ago. She was within a month of the end of her life at that point, but still able to contribute in a very meaningful way. And in fact, that is true for virtually all older adults. One additional challenge, I think, which is partly innate to the nature of the field and partly sort of reflects, frankly, I think some shortcomings on the terms of geriatrics experts, regardless of the specialty, is that we have tended to be complexivists. We focus on multiple contributing factors. We publish papers on 16 different approaches to how you could screen for X, Y, Z. Small wonder that frontline people are overwhelmed and even befuddled about what tool they could use to screen for what and how to approach a problem in a practical way. So again, tomorrow you'll hear more detail about the national movement, but the age-friendly health system movement is now several years old, funded by the John A. Hartford Foundation and spearled by the Institute for Healthcare Improvement, initial consensus was reached around this issue of complexity, around focusing on what has come to be called the 4M's, as both a way of making things more straightforward and democratizing the core expertise. And a certification movement in age-friendly care was launched, which focuses on what matters most: medications, mentation, and mobility. And you can see that there's some positive framing and a very patient-centered approach here, which hopefully helps to overcome some of the challenges of negative attitudes. You will, again, hear more about this tomorrow, and I suspect that many people on the call are familiar with the 4M's framework. But in many ways, the challenge is less that we don't know what needs to happen, but more that we haven't found a systematic way of moving forward, applying what we know, and frankly doing it. And that's what this quote from the German poet Goethe points to. So we looked a little bit about the disparities at the state level. If we think about Springfield area in particular, many but not all of you are working in that geographic space, it's even a more compelling need. The older adults in our area have a higher rate of multiple medical problems than the state as a whole, more self-reported memory problems, more documented dementia, higher rates of depression, more injurious falls, more reports with mobility and overall poor self-health. And this data, if you don't have it and are interested in it, is all from the 2018 Tufts Health Plan Analysis, which can be found on the Massachusetts Healthy Aging Coalition website. This is the community profile for Springfield. They don't give similar data on drug problems, polypharmacy, or what matters, but clearly both are still enormous problems within our system. You'll hear later, if you don't know already, a bit about our outpatient GeriPal team, as well as the inpatient ACE program. For both of those teams, when they began looking at healthcare proxy rates, about half of the patients lacked them. And frankly, healthcare proxy is rather a low bar in terms of determining what matters to older patients. In terms of polypharmacy, basically 100% of the initial group of 500 or so patients that our outpatient team saw had over 4 drugs, and the mean number of drugs was 13. So this is an issue as well. We began with our inpatient acute care for elders program as pilot in 2014. Pat Koffelt, who you'll see and hear from later today, is the nurse manager, the nurse clinician educator. She manages that piece on our unit and has been since the launch in 6 years ago, so she's an expert. We expanded to a 39-bed unit, multiple wards, lots of shifts over time, and things are in enormous flux in terms of COVID right now. But the heart is a interprofessional team reviewing cases and prioritizing and planning care on a daily basis. I tell you just a hair about the program now because this was one of the 2 first of the Baystate teams that formally joined the age-friendly health system movement, which actually resulted in the recognition of Baystate Medical Center as a whole as the first hospital in the country to achieve the recognition. Our outpatient team started with on-site team care, but is now focused almost exclusively on team-based home care for vulnerable older adults in the community. They've had many successes in terms of patient and family satisfaction, advanced care planning rates, reduced caregiver stress, and the identification of geriatric syndromes. First couple hundred patients, in fact, there was only one patient that didn't have at least one new geriatrics diagnosis. They were our second team that engaged, and as they achieved the appropriate goals, they secured recognition for our 3 community health centers as well. So what were the steps on the pathway? We needed to get support broadly within the institution to move forward. Department of Healthcare Quality helped us. Nursing leadership bought in terms of ACE, the community health centers assisted. We had IT support, had to pick the core members of 2 teams, join that first action community, and you'll hear a bit more again tomorrow from Kellyanne about that. And then think about, for specific sites and teams, how are we going to define the targets, the processes, and the reporting roles for those 4M's. We reported monthly on the numbers of patients who had received the 4M's care and did, Lord knows how many, probably hundreds of PDSA quality improvement cycles. And you'll practice some of that tomorrow as well. And we tried not to miss any opportunity to celebrate successes and achievements. We had a number of resources, some of which I've referred to before. Having an accountable care organization helped because of the emphasis that shifted to population health. And we had built links to the Institute for Healthcare Improvement, state and local elder affairs, the Mass Healthy Aging Coalition, our local coalition of community-based organizations, Live Well Springfield, et cetera. We chose to tie our progress on the age-friendly health system to Springfield's movement towards age-friendly and dementia-friendly recognition, and we're able to mobilize a lot of our partners from the Geriatric Workforce Enhancement Program work to collaborate on this, and succeeded in June of 2019 in having all 3 recognitions, the health system and the city for age and dementia friendly, announced on the same day, securing some visibility and press. That's the mayor and the health commissioner for Springfield, and some images of the team and the attendees who were largely older adults who attended that particular senior center. In the future, we're hoping to ramp up the numbers of patients served, and most importantly, and that's, I think, where many of you come in today, expanding the work well beyond geriatrics specialty teams. We're working on expanding an ECHO program. That's a virtual kind of a case-based coaching series that runs weekly, and some of you participate in that. The rest of you will hear more about it tomorrow. We're planning a similar project with area nursing homes, developing materials for community education on the 4M's, and thinking about how to implement and expand annual wellness visits to extend the reach of age-friendly care. There's also a resident geriatrics evaluation session focused on the 4M's that we're working on. So in summary, we've got some huge barriers nationally to the provision of high-quality care for older adults, but the age-friendly health system is one way of securing resources and minimizing the impact of those factors. Baystate Medical Center and the 3 community health centers, Brightwood, Mason, and High Street, were the first to be recognized in June of 2019. And in the future, Big picture will be expanding ECHO, extending annual wellness visits, working more with the House officers in training, and focusing on community outreach and education. So this has been a long journey. There is still a long way to go, but it's exciting for us, and I hope for you. And this is all about the team doing this